One of the most important topics to me is really the whole concept of patient-centered care. We started this well over a decade ago, and the idea is that in managing migraine, the real goal that we have with patients is to teach them to become the best managers of their own disease of migraine. And that may sound very simple on the surface, but it really is a very complex task. People with migraine have to make many, many decisions. When are they going to treat? What are they going to treat? With what are they going to treat? Then they have to make decisions about when they need medical care, follow-up care, when they might need to use preventative medications, and then there are a host of behaviors that become very important to integrate into the overall management of migraine. I think the foundation for doing this, however, is really having a good understanding of a disease model. I think everybody recognizes that migraine is sort of focused around headache, and certainly when we use the word migraine, almost it seems that it's synonymous with the term headache. But I'd like to point out that migraine is much, much more than headache. During an attack of migraine, people really are sick systemically. They have symptoms of nausea, they may be vomiting, they're sensitive to all manner of sensory stimuli, light, sound, odor, touch. There may be changes in cognition, changes in muscle tension, muscle pain, and really when the head hurts, the whole body suffers. So the foundation for helping people, I believe, is to give them a model that gives them an understanding of what migraine really is. First of all, we believe migraine is genetic, that there is a genetic basis for migraine, and people inherit a unique nervous system that is more easily excited, more hypervigilant, if you will, than people that don't have migraine. So I always tell patients that for your great-great-great ancestors, if you inherited a nervous system that was more vigilant, more watchful of the environment than other nervous systems, that it was easier to find food, avoid danger, keep track of the children in the clan, and hence it was a very useful attribute or asset in terms of our evolution. The problem is biologic evolution moves at a pretty slow pace, and I would argue that over the past 50 to 75 years, our social evolution has escalated almost exponentially. And things that your great ancestors' nervous system had to manage couldn't even be imagined in terms of what our modern day nervous system has to manage. Obviously, our ancestors never ate food that came from more than a quarter mile from the house or where they lived. It wasn't radiated, it didn't have herbicides and pesticides and et cetera, et cetera. They didn't, they didn't have computers, they didn't have microwaves, they went to bed when the sun went down, woke up when it came back up. And today all of those things are changed, and our nervous system is having to confront many, many stimuli that literally weren't imagined even as recently as 50 years ago. And the foundation for migraine and the headache of migraine is basically that the nervous system gets overloaded with all this information. Because what people inherit is an information-seeking, problem-solving brain. A nervous system that is highly vigilant, trying to figure out what it needs to do in the environment that it's in. And so when there's too many stimuli, it first of all changes the chemical equilibrium of the brain, producing symptoms that are not headache yet, but may be warning signs or premonitions, if you will, that someone is on the way to getting a migraine. And those are called premonitory symptoms, or sometimes a prodrome. Things like tiredness, fatigue, or maybe food cravings, or maybe muscle aches and pains that, if recognized, allow a patient to know migraine is starting. The next phase of this process towards the development of an attack of migraine is the aura. This occurs only in about 25 to 30% of migraine attacks and probably represents little short circuits in the nervous system that catch nerve cells that are irritated or activated, and when they get caught in this wave of electrical activity, they fire, producing the visual simulations, sometimes the numbness and tingling, and sometimes far more bizarre symptoms than that. But typically, aura symptoms have a beginning and end. They usually resolve before the onset of headache, usually lasting less than an hour and often much shorter period of time than that. Following that, you get activation of the nerves, first on the surface of the brain, and with that comes a mild headache. That phase is very critical for people with migraine to understand, because that's the timing for which our medications will work best. And that's the whole basis of early intervention or treatment of migraine while the pain is mild, meaning while the process of migraine is actually on the surface of the brain, and that's where the nerves are getting activated and releasing their inflammatory chemicals and their pain transmitting chemicals. And so our drugs can get to those nerves very, very readily if we treat early. If we don't, and migraine progresses, it moves from the surface of the brain to inside the brain, and when that happens, other symptoms typically emerge: the nausea, the sensitivity to light and sound and touch, and migraine becomes a much more difficult syndrome or disorder to treat. So that's a very important differentiation that people need to understand, because often they're looking at their medications, they're saying to themselves, well, I don't want to take it if it's not going to be a real migraine. I don't want to waste one of my pills that I only get a certain amount each month, etc. A lot of reasons that they may want to delay. But we know that if they do treat early, they're more likely to get complete resolution of migraine. The migraine is more likely to stay away and not return, and they're less likely to have side effects. So that's a major part of the education. Clearly, the hallmark of someone with migraine is that they have a nervous system that has this propensity, this ability to generate repeated attacks of migraine when exposed to these changes in their environment, either the internal environment or the external environment. They have this repeated attacks of migraine when these exposures occur. If we look closely, however, it's not just attacks of migraine that they have. They often will have other types of primary headaches or other expressions of headaches that this nervous system will create. And then also, if you look at the patient with migraine over time, a significant part of that population will actually generate what we call comorbidities. These are conditions that are associated with migraine, things like anxiety, difficulty with sleep, sometimes depression, irritable bowel syndrome, other pain syndromes like fibromyalgia, myofascial pain syndromes, back pain, many other disorders that can evolve, I believe, from this nervous system over time, particularly if migraine becomes more frequent, and specifically if there becomes a condition of chronic migraine, meaning you're having migraine headache on 15 or more days a month, or at least have migraine on some of those days and other primary headache disorders for a total of greater than 15 days per month. So when you put this all together, it's very important that people recognize the biologic nature of migraine. They recognize the points at which they can intervene and do something to manage migraine, to take control of it rather than having it take control of them. The other thing I like to point out to people with migraine, and this is a little more controversial, but I do like to make sure people understand their brain is not broken. You know, the migraine brain actually brings with it many attributes, especially when it's functioning well. People with migraine tend to do well with school. They often do well with artistic effort. They're often very well organized. They're very aware of the needs of situations, things that have to be done and should be done. They're very aware of the feelings of other people. I always teasingly tell them sometimes their own feelings may get hurt a little easier than other people. They often are light sleepers. They get cold hands, cold feet, and sometimes like to skip breakfast. So there's all these kind of unique things, but the foundation is that when migraine is well managed, this nervous system often brings with it many attributes. And that's really the goal of helping people manage this, is to bring those things that are bringing them success, and of course minimize the number of headache days or comorbidities that they might experience over a lifetime.